Okay, this is the one I'm sure everybody has been looking forward to on your diabetic medications. I hope now I can actually go into it more since Dr. Baker's talked to you about diabetes. You have more of an understanding of what it is, what has to be done, and I am going to try to make it as understandable as possible for you. Okay, so insulin, you know about rotating sites. Don't massage it after giving you injection. You actually can hold pressure on it for 1 minute. If you give a long-acting insulin, a basal insulin, you actually teach the patient when they put the syringe in to hold it for a minute before they pull the needle out. Like I said, you can apply pressure. Lipodystrophy. That's you have to rotate your sites around to prevent the lipodystrophy or the destruction of that subcutaneous tissue that will occur due to not rotating. But if you let that site rest for a while, it will repair itself. Pearson actually does a really good job with the insulins, and I'm going to mention different page numbers I found things on as I go along here. There is insulin discussion in your Karch book. Mostly it's getting those scales and which insulin does what, but hopefully I can cover it in here. Now remember your type 1 diabetes. Let me go here. Your glucose, your insulin is needed for glucose to get inside the cells so it can be used to make energy. That's the simple explanation of it. Now, I remember in Pharm last semester some things people got confused on. Endogenous comes from inside our body. Those are people that still make insulin in their body. That is all of us, anybody that's not diabetic or the type 2 diabetic. Type 1 diabetic no longer has endogenous insulin or insulin made in the body, so they have to get it from the outside, exogenous. So a type 1 diabetic will have to have insulin injected their entire life. But a type 2 diabetic still has some endogenous insulin. And so they don't always need the exogenous. Hopefully, now that you've learned about diabetes, that makes more sense. So the type 1 diabetic needs lifelong exogenous, outside of the body, source of insulin to be able to stay alive. Now, who else needs insulin? So the type 1 diabetic needs insulin. The type 2 diabetic will need insulin if it's not controlled with a diet and with oral hypoglycemics or other types of hypoglycemics. Sometimes the newly diagnosed diabetic who has so many risks, the glucose is so grossly elevated and they have to be on insulin right away. A diabetic, type 2 diabetic, or even some people that are not diabetic will have to be on a temporary insulin because of increased stress, like major surgeries, hospitalizations, severe infections. The gestational diabetic or a type 2 diabetic that is pregnant, and if they cannot control the blood sugar with the diet and exercise, because you cannot take the oral hypoglycemics medications during pregnancy. Insulin can be needed even if it's a type 2, but diabetic, that goes into diabetic ketoacidosis or HHS, which should have been covered by Dr. Baker, or at least to some degree, and temporarily need to be on insulin if they're getting high calorie intake, such as through tube feedings, parenteral nutrition, whether it be TPN or PPN, any kind of parenteral nutrition. I did not say Pearson discusses how insulin works in the body, page 819. It also makes a note, talks about all diabetics, type 1 and type 2, that have any kind of vascular disease or have an increased CV risk, cardiovascular risk factors, which could be smoking, age, family history, male, different things, should be on a daily aspirin regimen, whether it's 800 or 325, low dose or regular dose, unless there's a contraindication, and you should know contraindications for aspirin. So insulin administration, that's also in Pearson on page 821. They have a figure 12.7, which looks just like this one here. It is recommended insulin be given in the abdomen as much as possible, because that is the site of the most rapid absorption. The next site to be chosen would be your deltoid, and then the third site as far as for absorption would be your thigh, and given it in the hip is the very last. And this would be even beyond that, because you want to give it where it's the most rapidly absorbed, which is the abdomen. And I think we all have plenty of subcutaneous tissue to spread around in our abdomen to rotate sites. I used to teach patients to go this side of the abdomen, this side of the abdomen, deltoid, deltoid, abdomen, abdomen, deltoid, deltoid. A lot of people like to give it in the thigh. Patients giving it to themselves, give it in the thigh, but that's a third in absorption. Also, you don't want to give it in a place that's going to have heat on it, or like they're getting ready to walk. You don't want to give it in the thigh or somewhere where they're going to apply heat, because that's going to increase the absorption of insulin, decrease the length of time, and risk for hypoglycemia. This is an insulin pen. That's multiple different insulins come in pens now, where it can dial it in, which is so much easier for people with limited problems with eyesight or manipulation. Should know about drawing up your insulins, clear before cloudy. Take your insulin out of the refrigerator. Do not give it cold. Do not shake it. You roll it in your hands. This is a picture of an insulin pump. You want to make sure your insulin pump is functioning. You change the site of the needle every 2 to 3 days, 3 days maximum. Check the site for infection. And I think I talk about that in a little bit, to make sure if they're hyperglycemic, you're checking to make sure there's insulin in your pump, that your pump hasn't malfunctioned, that it's not kinked, that the needle hasn't come out. You'll always check to make sure it's functioning before you make assumptions. Insulin, regular insulin. It's short acting. It is clear. If your regular insulin is cloudy, you should discard it, not like the MPHs that are cloudy. Regular insulin, that's another one people had trouble with in Pharm. Regular insulin is the only one that can be given IV. Insulins are all given parenteral, which is the sub-Q, on an absolute emergency with no IV access site, needing to get the blood sugar down. Only then will insulin be given IM, and I have never seen it given IM. But it can, if it's absolutely necessary. It cannot be given orally, because that the gut will break it down and you will not absorb it. So regular insulin is given IV. It's the one that's used to treat DKA, or diabetic ketoacidosis. And it's when a type 1 diabetic is newly diagnosed, they always start them on a regular insulin, and then they add in other ones such as NPH. Insulin can be given in 100 units per mil or 500 units per mil. 99% of the time you're going to see 100 units per mil. I have actually seen the 500 units per mil, very, 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 very rare. That's when a person has to get mega doses of insulin, and they're just so resistant to their body using the insulin. Nursing, I said it's parenteral, which is subcutaneous. The only IV one is regular. An insulin pump, that's what your CS2 device is your subcutaneous insulin pump. It is in the subcutaneous tissue. I did say that you're changing the needle every 2 to 3 days, minimum, maximum every 3 days. The text, Pearson, page 820, talks about all this. It also tells you in your skills book, volume 3, skill 2.35, talks about insulin pumps, administration, all those things. I think it would be a very good idea to look at that. Your pump is programmed for 24 hours to give a set dose. It also can be programmed, or they can go in and do boluses. Like sometimes you'll see people with an insulin pump and they'll have it programmed. They're getting a steady, regular insulin, and when they count their carbs at their meal, they will give themselves a bolus of insulin. Always check for malfunctioning of that insulin pump. Usually in the hospital, they're going to take that insulin pump out and they're going to probably put them on IV or sliding scales other ways. Oh, regular insulin, or all your insulins can be at room temperature for 4 weeks. Okay. And pH insulins are the ones that are cloudy. You only mix your insulins just prior to administration. Your long-acting insulins, the glargines, are never mixed with your other insulins. Glargines have no peak. It's a constant effect. Always make sure with insulin there's no air bubbles, because if you've given insulin or you looked at an insulin syringe, just a little air bubble is going to maybe obstruct 5 units of insulin to make a huge difference in managing that patient. No bubbles. Okay, pumps allow more normal regulation. I'll let you read this. I'm not going to read this slide to you. This is a slide you've seen before. There's also a table in Pearson, table 12.5. Actually, I don't have the page number in front of me. I'm flipping. 12.6. I'm looking. Shoot. Of course I can't find it. I'm looking. Anyway, table 12.5 in your Pearson text goes over the insulins. This isn't one I had given you. Make sure you understand the onset and peak. Like here, you have the Lispros, which is your rapid acting. Then your fast acting, your intermediate acting, and your long acting. So knowing your insulin onset and peak, so you can figure out meals and symptoms and that sort of stuff. Table 12.5 on whatever page it is in your Pearson. Okay, so complications, of course, is hypoglycemia, cold and clammy, need some candy is just a really good thing to remember. You can give glucose, D50 syringe. You've probably seen that done before. Glucagon can be given subcutaneous, IM, or IV. Do not use unless the solution is clear. Also in your Pearson, page 823 has a section on sick day management that you may want to look over. Complications, DKA, which I'm sure was covered by Dr. Baker. You have to give them fluids. Look at this, 8 to 10 liters of normal saline. And this is 0.5 or half normal saline. This is normal saline. To replace the fluid loss, regular insulin only when they're in a DKA or HHS. Monitor electrolytes, especially your potassium. Insulin decreases the potassium level in the body by redistributing it into the cells through the sodium-potassium pump. A large part of the shifted extracellular potassium would have been lost in the urine because of osmotic diuresis. Hypokalemia or low blood potassium concentrations often follow the treatment. So you're monitoring your potassium, you're monitoring your glucose, you're actually, when your insulin, when you start to get it down, you actually end up changing at some point to D5, but I'm not going to go into that and confuse you. Okay, hypoglycemic agents. Hypoglycemic agents are used to stimulate or increase insulin secretion. Pearson doesn't go into it much. It talks about some, like the Byetta or exenatide. Karch has a bunch of things. Let's see, I wrote a note here for myself on the Pearson, page 839. May have insulin added if they're in the hospital. Type 2s may have insulin added even if they're on oral hypoglycemics, except in the hospital. They usually don't give the oral hypoglycemics because of the risk of hypoglycemia. Okay, now, this is the crazy slide I showed you. I know the text, your Karch has lots of information. Now just listen and take notes. I am going to speak slow for me and try to make it where all this makes sense. You have your chart in your text of Karch, table 38.3, page 642 and 643. I'm going to tell you what ones you don't need. Your first generation sulfonylureas, cross that out. On your second page, your SGL2 inhibitors, cross those out. Now, I am going to do my best to clarify the others so you can get this straight. So your second generation sulfonylureas, they are glimepiride, glipizide, and glyburide. They stimulate insulin release from the beta cells. They also can increase the binding with the insulin and increase the number of insulin receptors. It's given right before the meals. So there is a risk because it's increasing insulin release, so there is a risk for hypoglycemia. If the type 2 diabetic is on insulin if they start on a second generation sulfonylureas, they may have to decrease their insulin dose. It is contraindicated. All these are contraindicated. These hypoglycemics drugs are all contraindicated in pregnancy. Every single one that we're going to cover, except for one, and I will tell you when, are not given in type 1 diabetes because you have to have a functioning pancreas. If you're going to stimulate the pancreas, the beta cells secrete insulin, you have to be able to produce insulin. Type 1 diabetics do not produce insulin. Second generation sulfonylureas, GI upset, and diarrhea are major adverse effects. Second, alpha glucosidase inhibitors. Those are acarbose is the only one you need to know with this. It's not given very often. It has to be given at the start of each meal. Does not cause hypoglycemia. It is an additive when you're giving them everything else to control their diabetes and you still can't control them, they might add in acarbose. It has a risk of hepatotoxicity, so of course there's caution if they have hepatic impairment. It functions by inhibiting the enzyme that breaks down the glucose for absorption. It only delays this glucose absorption, doesn't stop it, so it's not the best. But if all else is failing, you're on everything else, they may add in acarbose. Next is your bigunide. The only one is metformin. Metformin decreases the production of glucose and it increases the uptake of the glucose. So it does not decrease. It does not increase release of insulin, so it does not cause hypoglycemia. So metformin will try to get you to use your insulin better, decrease and by increasing the uptake of the glucose, but it does not cause hypoglycemia. It's used in type 2 diabetics. It may be used for an insulin-resistant person that's not true diabetes yet, and for PCOS or polycystic ovary syndrome. There is a risk for lactic acidosis. You'll have that muscle pain. You want to watch for that. It does cause GI distress. It can cause diarrhea. Usually the body adjusts to it and that resolves. It can be given in children age 10 or older. Then you have your DDP4 inhibitors, allogliptin, limagliptin, saxagliptin, sitagliptin. If you notice, the DDP4 inhibitors are the gliptins. They slow the GI emptying, decrease the glucagon secretion. They inhibit the DDP4 enzyme. DDP4 enzyme, GLP, let's see. Okay. Inhibit the DDP4 enzyme, preventing inactivation of endogenous GLP-1. So endogenous, that's made within our body. GLP-1 is a hormone that stimulates insulin secretion from the beta cells. So this DDP4 enzyme kills this hormone that stimulates insulin secretion. So the DDP4 inhibitor blocks that so that your beta cells can secrete this hormone and increase your insulin secretion. So it works by prolonging the effects of insulin secretion. It's given once a day. It peaks in 1 to 5 hours. Minimal, if any, really not a big risk of hypoglycemia in it. Has very few effects other than the fact that it might increase the risk for pancreatitis. Number 5 is your human amylin. Your one is primatide acetate. Your human amylin. Amylin is normally made by our body, produced by the beta cells, and it regulates your post-meal glucose. So when you're having a problem with that, this is primatide acetate is given to work as your human amylin. This is the exception. It is given in type 1 and type 2 diabetes because it's taking the place of something that normally would be released by your beta cells, but your beta cells are not working in a type 1 or type 2. So it takes the place and helps regulate post-meal glucose. It is given subcutaneous. It's given before major meals. It prevents that post-meal glucagon release or your hepatic glucogenesis. So it prevents that elevated glucose. It also controls gastric emptying, increasing satiety, that stimulation in the brain that tells you that you're full. Then the next one, your 6th one, is your incretin mimetic. Remember, the word mimetic means to mimic, so it mimics incretin. Incretin is the hormone that's released from your gut during your meals. It's glucose-dependent insulin release from the pancreas. So when your body is no longer having this stimulation for your pancreas to release your insulin, this incretin mimetic, the only one you need to know is your exenatide, or maybe known as Byetta. Exenatide is an incretin mimetic, so it mimics your incretin to release insulin from your pancreas in response to your glucose level after a meal. So it enhances insulin release by the pancreas secondary to glucose levels. It decreases the glucagon secretion or your hepatic glucogenesis. It slows gastric emptying. Do not give if the person cannot eat. It is given subcutaneously twice a day or BID within 60 minutes of the morning and evening meal. They now have an extended release. I think I've seen it advertised on TV, where there's an extended release that is given once every 7 days. It has a rapid onset. It peaks in 2 hours. It lasts 8 to 10 hours. And it can be given as an adjunct with oral hypoglycemic medications. Your next is your GLP-1 agonist or GLP-1 receptor agonist. Or remember, your GLP-1 is the hormone that stimulates insulin secretion from the beta cells. So your GLP-1 agonists are abglutide, dulaglutide, liraglutide. All of these, if you notice, are the glutides. GLP-1 agonists have the glutide in them. You may know Trulicity and Victoza. They increase the insulin release. They decrease glucagon release or the hepatic glucogenesis, slow GI emptying, and stimulate satiety in the brain. So if you feel full, it's given subcutaneous only once a week. Unfortunately, there is a risk for thyroid tumor, so if they have to risk benefit on those. It was great when these came out. They were getting used a lot, but there was a lot of GI distress that I saw in people, but with the risk of thyroid tumor. Then you have your meglitinides, nataglitinide, and repaglitinide, which is Starlix and Prandin. So both of those, if you notice, have the glitinide in the name, meglitinides. They increase insulin release. It's given orally right before each meal. So there's definitely a risk for hypoglycemic because it's increasing your insulin release. Risk for GI upset and diarrhea. It's also given in combination with metformin. Believe it or not, your very last one is your thiazolidinones. That's your praglitazone or Actos and rosiglitazone or Avandia. You have your glitazone in both of those. It inhibits the enzyme that breaks down glucose for absorption, so it's only delaying things. It's not a huge effect on glucose level. It's only when you can't control the glucose and risk for hepatic toxicity. Oh, did I already talk about those? I don't know. Anyway, so that is it for your diabetes lecture.